Thank you very much, and thank you for inviting me here, and particularly Felix, with whom I worked on one of the study I will present to you. You already had two very sexy talks this morning, and I hope that I will not disappoint you too much, because as you will see, and as you just introduced, the data are really limited for randomized control trial in pediatric heart failure. So I think that we need to elaborate together to go forward and to have more clinically meaningful results in this field. So I officially put here my disclosure because it's important, and I think it's important for many of us to participate to advisory board and steering committees to design the ongoing and the future trials in pediatric heart failure, but also in other fields in pediatric cardiology, and we have to be involved. Otherwise, the design of the study will not be as adapted as we need them to be for all the patients that we have, and starting from the younger stages. So the importance of the problem is huge, because I just put here the two survival curves from registries on pediatric heart failure related to dilated cardiomyopathies. And as you can see here in the recent registries, yeah, I don't know if it is this one, but that's not a problem. On the right side is the overall mortality, and on the right side for you, this is the mortality related to age, and you can see here that there are differences between the oldest and the youngest patients, probably related to the difference in the etiology. So today, the burden of pediatric heart failure is very important, because the mortality is still very important. The survival, as I told you, depends on age at presentation, but also depends also on the cause. That is a major predictor of outcome. For example, familial cardiomyopathies have a higher death rate than non-familial, and as you know, myocarditis or proven myocarditis have a lower mortality. Recovery is also possible, and it's a big difference between adults and children, because recovery of the left ventricular function has to be taken into account in the trials and to predict the outcome, as well as the number of patients to be included. And we know that it has the cost is very important, the cost in mortality for a child admitted for heart failure, but also the cost in money. And today, we don't have really information from randomized controlled trial on mortality. I will show you a couple of these randomized controlled trials, but the data from these trials do not prove that we are efficient in reducing morbidity and mortality. And so today, all the guidelines are level C, so it's expert opinion, so eminence, but not evidence-based medicine. In the adult world, the drugs in heart failure have proven to be efficient in reducing mortality, but also mortality translates in hospitalization for heart failure decompensation. But in pediatrics, there are some reasons why we cannot prove that. The first is the design of the trial. That's why it's very important to be involved in them. And the trials are difficult to design, of course, because the number of patients is very limited. If you look at the number of patients included in an adult trial, it's thousands of patients are included. And to collect thousands of patients with pediatric heart failure is particularly difficult, because we are dealing with rare diseases. Also, because the number of events is also limited. I mean, mortality is, I showed you that it is important, but at the end, for a duration of a trial, for let's say a 1 year or a 2 years period, the mortality is quite low. So it's difficult to power a trial with that. Surrogate, I will discuss of that later. And we have also very important heterogeneity in the heart failure causes in pediatrics. There are factors related to the kinetics and pharmacodynamics of the drugs in pediatrics, and I will not elaborate on that. There are also different diseases, and it is the topic of this meeting. For example, and it's obvious, LV is not a RV, but also LV is interacting with the RV, as we heard this morning, and also single ventricle is not a LV for designing trial. And finally, there are also developmental aspects for the expression of the beta receptor that is different in the RV and the LV, but is also, there is an ontogenic modification with time. So this may create problems. So this is just an example of the guidelines, and we all do that. We give ACE inhibitors, beta blockers, potentially aldosterone antagonist, and pulse furosemide. But if you look at the quality of the different trials that are plotted here from this paper, the green are those with good quality, with good quality trial. And you can see here that this is the trial of a Congenital study. This is the only one, but also with 2 question marks, that was properly designed to reach the endpoint. The other ones are not. And you can look into the literature, they're almost known with all green dot here. So the question is finally, is it possible to demonstrate the efficacy of a new compound in pediatric heart failure? And for that, I think it's important to define 3 items. The first one is the predictor of outcome. The predictor of outcome is something that maybe we don't have in some disease, and particularly in disease of the RV. It is a parameter that is measured at baseline, and its initial value predicts hard outcome. For example, right ventricular ejection fraction in tetralogy of Fallot predicts death. That's a predictor of outcome at baseline. The second item is a therapeutic target, and this is important in our daily practice. The therapeutic target is first a predictor of outcome, so the baseline value correlates with outcome. It is in the pathway of the disease, so it has to be physiologically pertinent to be in the pathway of the disease. And it's important that the treatment that you will apply change the value of this parameter, and that the change predict the outcome. Okay? So this is a therapeutic target, and that's for us doctors. And the third one is a therapeutic trial endpoint. It is not exactly the same, because the agencies, and particularly the FDA, but also the EMA, want that the therapeutic trial endpoint is clinically meaningful for the patient. So, for example, improving right ventricular ejection fraction has no mean for the patient. It has to improve his quality of life, WHO functional class, or something like that. And the drug will not be approved if it's just a surrogate, like the ejection fraction of one ventricle. And of course, it should do no harm. So we will not go into all this busy slide, but this is the Congenital trial. So the Congenital trial was designed to analyze worsening in children with heart failure, but also, and that was very original, improvement. That's the drug improved clinical status, and also the third was unchanged. So this was one of the biggest trials that was designed and led by Bob Shaddy. And this is just the flow chart, and you can see that more than 150 children with heart failure were included in the trial. But if we look, I don't know if, yeah, sorry, it does not appear on mine. On the endpoint, all-cause mortality, cardiovascular mortality, hospitalization, etc., it was a failure. So no demonstration of efficacy of carvedilol in this group. Why? And so it's very important to go back to the trial and try to analyze why. So first, it was a mix of different disease, and probably we should not do that, but sometimes it's difficult to include patients with rare disease, and different ventricular morphology. The endpoint was a composite one, improvement and deterioration. So it's also a very important difficulty, and it was not validated from registry, for example. The estimation of improvement was not appropriate, and also something important, the children who were included in the trial were in good condition, functional class 2. So probably we should include more severe patients. So there are different new chronic heart failure drugs that have demonstrated some efficacy in adults, and I will go a little bit into details. The first is ivabradine. It's a modifier of a potassium current, and you know it. The second one is LCZ. It's an association of angiotensin-neprilysin inhibition, and valsartan. And the final one is stimulator of the guanylate cyclase. So the ivabradine, the idea was that if you reduce heart rate more than it is reduced by beta blockers, does it improve prognosis? And so the beautiful studies show that if the heart rate in heart failure is above 70, you have a worse prognosis than those with a heart rate below 70 for mortality and hospitalization. So then the trial was designed, and it was the SHIFT study, and probably you all know this trial, that reached the primary and secondary endpoint, cardiovascular mortality and hospitalization for heart failure, if you add ivabradine on top of standard of care in adult heart failure. So we participated many European centers in the ivabradine study in children, and the endpoint of this study was the reduction of heart rate from baseline on top of standard of care. And standard of care is described here, and you can see that in Europe, the standard of care associates ACE inhibitors, diuretics, and beta blockers in many patients, so that was really an important information to see that the standard of care is quite homogeneous in Europe. And the patients who were included were dilated cardiomyopathy with the ejection fraction below 45. And the study was positive for the primary endpoint. So reduction of 20% of heart rate, but more important, but the study was not powered for that there was a trend for improvement in WHO functional class and LV ejection fraction in this trial that included more than 100 children with chronic heart failure. So the positive aspects were the number of patients, the quality of data, the pharmacokinetic data, safety information, and trend in improvement in WHO functional class and ejection fraction. But the limitation is that what does ejection fraction means for a kid, and what does reduction in heart rate means for a kid? So we don't have any information on hospitalization and mortality. So it's important. It's one of the important trials, but it does not today prove something very pertinent for the clinical practice. For the LCZ, you know the paradigm study on the right side. It's a comparison between LCZ and valsartan and enalapril, and there was a superiority of this new drug and this Entresto for the primary endpoint, hospitalization and mortality. And there is an ongoing trial in pediatrics called Panorama HF that will include more than 300 children with LV ejection fraction below 40. And it's a quite homogeneous group of only dilated cardiomyopathy with limited causes. And if it is a systemic ventricle, it should be a left ventricle to participate into the study. And there is a specific galenic. And we hope that we will have new information, particularly because we design a new endpoint that is the ranking that takes into account deterioration and improvement. And we powered the studies for that, and it's a new endpoint that might be useful for future trials in pediatrics. So I'll skip that one. Finally, the stimulator of the guanylate cyclase. You know the inhibitors, but this is the stimulators. And their role is numerous into the cells. There were two trials in the adult, the Socrates, and so it shows that it reduced the NT-proBNP value and improved outcome. And so the Vectora study was designed and the primary endpoint is mortality and cardiovascular hospitalization. And so we will have these results in the future. But there was a former trial called Dilate, and I think it's important, and I will not go into detail, but it shows that this type of drug might improve diastolic function of single ventricles, but also of left ventricle in this specific trial. So maybe we could use that in the future for single ventricle, and you may be aware that the different trials are ongoing with riociguat in univentricular hearts, with or without elevated pulmonary vascular resistances. So SOCO1 and SOCO2 studies will start potentially in 2 or 3 years with vericiguat in pediatric chronic heart failure. So now for my last slide, I will elaborate a little bit on congenital heart disease and potentially the design of future trial. First, in chronic heart failure in congenital heart disease, I think is different topic from cardiomyopathy, because the question is, and it is from this scientific statement, should we intervene before overt heart failure, or only when there is overt heart failure? So prevention of deterioration of the function of any ventricle is a pending question. And so maybe the design of the trial should take into account this type of strategy. And we know also for the endpoint that it might be really difficult because the mechanism of physical intolerance, and maybe the model will be very interesting to explore this type of issue in patients with congenital heart disease. And the causes are numerous and potentially not well known. And maybe we could discuss of that, but for the systemic right ventricle, the mechanism might not be only systolic dysfunction, but also the contribution of the atrium to the right ventricular filling, particularly during exercise. So the endpoint should be adapted to that. For the systemic right ventricle, we know that there is a progressive decline in right ventricular ejection fraction with time, and that it is closely related to mortality, either after the atrial switch on the left side, but also in congenitally corrected transposition. But today, all the trials that explored the efficacy of any heart failure drug in a systemic right ventricle failed to reach the primary endpoint. And I just give you here the example of the Valsartan study led by Barbara Mulder. And this study this was the endpoint: heart failure, supraventricular arrhythmia, ventricular arrhythmia, reoperation, and death. And it was a composite endpoint. And this study failed to demonstrate any efficacy. But if you look at this, and I will not criticize this very important and interesting trial, but personally, I completely do not understand the endpoint. I don't know what it means, and for me, it means nothing to have a composite endpoint with that. Potentially, heart failure episode is only a pertinent endpoint. So the design is probably the cause of the failure. I just show you here the TEMPO study. It's another way to look at the endpoint. TEMPO study is bosentan in univentricular heart and looked at the exercise capacity with VO2. And it shows increase in peak VO2 in patients treated. And it shows also an improvement in WHO functional class. But my question is, the treatment effect is 1 ml per kilo per minute. So, okay, the trial is powered, but what does it mean for a patient to have a 1 ml per kilo per minute improvement in VO2? So, positive study, circulation, but maybe it does not mean anything. But what we know, then now if you analyze a posteriori, you can see that if you increase your VO2 and if you start very low, then you improve mortality. And it is true in Fontan that peak VO2 is a predictor of outcome, and that on short term, if you improve your CPET, you improve your risk of hospitalization for failing Fontan. Maybe not death, because the study was not powered for that. So, okay, it's a little bit increased, but it's clinically meaningful for us, so certainly we could do study with that. What are the ongoing study or future study with the RV? The REDEFINE trial is a study designed to test losartan in patients with tetralogy of Fallot and right ventricular dysfunction, and the primary endpoint is a surrogate, right ventricular ejection fraction. Potentially this study will be positive, but I don't imagine that it will do any good to the patients. I mean, anything to the patients. And it's the same for the tadalafil in single ventricle. Okay, the question is, does it change the MRI? But there is no question about the patients, so I think that it's an opinion. Huh? It's a useless study. How can we improve that? The improvement is there are different enrichment strategies. First, we have to decrease the population heterogeneity, so all the patients should resemble one another. That's very important. So no mixed patients. And we should also have prognostic enrichment strategy. it's important that we put into trials patients that will have an event, that will deteriorate, for example. So we should put the more severe patients in trial. And we are quite reluctant to do that, and the industry is also reluctant to do that because they don't want the patients to die into the trial. But if we want to increase absolute effect difference between groups, we should include the more severe, and we should also have predictive enrichment strategy to choose the patients that will reach the endpoint. And so we have to have data from registry to predict this type of patient. Just an example, in cardiomyopathies, this is a study of my group, not published today. If you include patients at time of diagnosis with cardiomyopathy, then some of them will do good, some will be hospitalized. And the question is, should we include the patients after when they are readmitted for heart failure? Then if you include only this population, you will have a lot of events and power your trial. But you should not include this one that will recover. So we will not go into this complex slide, but I recommend for those who are interested in trial to read this paper published in Orphanet Journal of Rare Diseases a couple of years ago. And this is how to design trials in pediatrics, depending on the fact that you want the child to be on placebo, not on placebo, that you have a reversible or non-reversible outcome. So then you can have different types of design. And if I just give you an example, if you want to test a drug on pediatric heart failure, and if you want to have a reversible outcome, for example, hospitalization for decompensation, and if you don't need a rapid response, but maybe a slow response, you have a couple of months in front of you to do the trial. If you don't care about the time on placebo, and then you can go into this direction, and you should do this type of trial, so it's parallel group or factorial group. But if you have another criteria, then you can have other design, for example, withdrawal. You withdraw a drug, and that may be also possible in pediatric heart failure. So as a conclusion, I think, of course, that we need to improve outcome of children and adults with heart failure related to CHD. We have to remember that it took 2 decades to find another drug efficient in chronic heart failure in adults. So it was ivabradine, and then now we have LCZ, but before there was no other drug. I think that we lack international registries, because from registries, sometimes you can have information on predictors of outcome, therapeutic targets, but also you can make a drug being approved from standard of care practice, and this has been done for devices in the United States. And the next step that might be more complicated is that today we manipulate drugs in heart failure as we do in pulmonary hypertension in combination. And maybe one very simple trial would be to test standard combination of therapies in children to see what is the best choice in this situation. Thank you very much.